Hi, so I'm Asif Kasim. I'm a cardiologist by training. I work in London, both in the NHS and private practice, and also I'm a technology entrepreneur, and I've been involved in online networks and online medical education for about 20 years. As a doctor, I'm a consultant. I work at Croydon at King's, do some private practice in London, and that includes both general cardiology and interventional cardiology, so doing procedures to fix arteries that are narrowed or blocked. So as a doctor, your prime objective is to improve patients' care, make them live longer, healthier, happier lives. And that translates into lots of different things. Partly it's around making sure you're good in your patient interactions and clinical skills and diagnostics, but also about knowing what the right treatments are for patients. And a lot of that in modern medicine is driven by algorithms, it's driven by clinical guidelines, it's driven by expert consensus. And so in the UK, as a cardiologist, use your clinical skills to treat patients, and you often do that within a framework that's defined perhaps by things like the NICE guidance in particular specialty areas. It might be defined by the European Society of Cardiology guidelines, and then beyond that there are those areas where individual patients, individual scenarios that you work on. Those treatments appear at one of the big conferences, so it might be for a cardiologist at either the American College of Cardiology or one of the big interventional conferences or European Society of Cardiology, and typically you'll get the presentation of the trial, you'll get a simultaneous publication, for example, in the New England Journal of the Lancet, and that will raise everybody's awareness. It might lead to some early prescribing, but it feeds then pretty rapidly into things like NICE guidance, local guidelines, prescribing, and so on. So there's a relatively well-established process around those things. And I think maybe within cardiology, heart failure treatment probably reflects this the best. Heart failure has a terrible prognosis. If you've got a poor left ventricle, the prognosis, if you've got NYHA 3 or 4 heart failure, is pretty much the same as having colon cancer. However, in the last 10 years, drug treatment has improved hugely. And what that means is patients presenting with heart failure who are put onto that guideline-directed medical therapy, their symptoms are better, they're less likely to go to hospital, they live longer, healthier, happier lives. So those core objectives that as a clinician we want to do are coming through. Field sales reps and pharma companies in the hospital, they'd be making appointments to see you, whatever grade you're at. They would provide lunches, you go out for dinner, you see them all the time, and there'd also be a lot of physical leave behind in terms of literature. That certainly meant there was a more direct personal relationship there. I'm not sure what impact that had on prescribing, but I think it may have had some. I think when we look at it now, if you take those examples of those heart failure drugs, as soon as we see the trial data being presented, as clinicians we start talking about it. We start talking about it in relation to specific patients. I've got this patient here, I think they'd benefit from that drug, and you do that in person, it happens digitally, it happens in meetings and forums as well. And also that peer-to-peer reinforcement is, yes, we should be using it, is probably pretty well established before it hits a clinical guideline or it hits NICE guidance and so on. And if you think about the pharma influence in that, it's hugely variable depending on how the companies engage. So ideally, as a clinician, what you want is to have ready access to data, both in terms of the original publication and the highlights of that. And so that might be a well-crafted, short form video or an infographic or some kind of data from the company. And I think increasingly that the interaction with the pharma company comes in a different way, where it might be around trying to persuade a prescribing committee or guidance or so on and saying, look, these data are really strong. They work to get the clinicians on board to support that. And in some cases, that then becomes an alliance between the clinicians and the pharma company pressing for either local prescribing or guidance to be changed. Pharma companies can support clinicians, for example, to find the right patients to make sure they get on the right treatment. So if you take heart failure again as an example, yes, new patients coming through are much more likely to get guideline-directed medical therapy. They're seen by a heart failure specialist, they're probably plugged into a heart failure specialist nurse, and they're titrated onto the right meds. However, what we also need to do is to reach those patients who are under chronic care with a general practitioner or a general cardiologist, they might not be seen more than annually, they might not be seen at all unless they have a decompensation.